Let's now, if we can, move on to our next presenter, Dr. Marianna Golts. Dr. Marianna Golts is the Assistant Professor of Psychiatry at the University of Toronto, and Dr. Golts is interested in perinatal health at Mount Sinai, where she is professionally located. And I'm very pleased to say also that Marianna is working with us at the Canadian Rapid Treatment Center of Excellence. Marianna, great to have you with us. The virtual floor is over to you.
Thank you, Roger. Good morning, everyone. So I'm going to be talking about the management of mood disorders during pregnancy and the postpartum period today. And I'm going to try to go through this quickly and leave some time for questions. So I'm going to review the treatment of depressive disorders in pregnancy and the postpartum period with the focus on the safety of antidepressant and mood stabilizing medications. So we know that women can experience depression at any point in their lifetime, and particularly women are vulnerable in the phase of life where they're likely to get pregnant and have children. So there used to be a thought that pregnancy was protective for depression, but in fact, the rates are the same in pregnant versus non-pregnant women for depression, and the prevalence in pregnancy is about 10 to 15% for depression. Postpartum, after delivery, due to hormonal changes that happen, many women have the postpartum blues, and that's not considered a disorder per se. That's more related to the large drop in hormones from the pregnant state to the postpartum state. Usually occurs day 3 to 4 postpartum, and people are, more tearful, may have difficulty sleeping, but their functioning is preserved, and that's really important to differentiate the blues from postpartum depression. If the blues persists for like 2 weeks or longer, one starts to worry about the risk of postpartum depression. And the general prevalence of that is, depending on which study you look at, between 10 to 22% of adult women. Seems to be a bit higher in like adolescent mothers. And lastly, in terms of perinatal disorders, there's postpartum psychosis, which is much less common. The prevalence is about 1 per 1,000, but significantly concerning because it presents with higher risks of suicidality and infanticidal ideation. And often postpartum psychosis presents very early on in the postpartum period, usually like day 3, 4, 5, but almost always within the first 2 weeks postpartum. And interestingly, women don't present as acutely psychotic, but more complaining of confusion, memory impairment, and difficulty bonding with the baby. In terms of risk factors for perinatal depression, if you've had a previous episode of postpartum depression, there's a very high risk of reoccurrence, up to 50%. If you have depression in the current pregnancy, the risk of postpartum depression is about 30%. And other biological risk factors are if you've had any prior episode of major depressive disorder, if there's a family history, particularly of postpartum depression, that seems to increase people's risk. Discontinuing medications in the first trimester or prior to pregnancy increases risk for people with severe depressive disorders, and also significant medical and obstetrical problems. Obviously, there's also psychosocial risk factors that contribute to depression, and those seem to be kind of more intuitive. Why should we treat depression in the perinatal period? Women often don't want to take medications in pregnancy and are obviously understandably concerned about the impact of that on the fetus and sort of on the child later on. But depression is not benign, and we know that it also affects the fetus and the developing child. So from the STAR-D report, there's a STAR-D child report that was written up by Myrna Weissman, and it suggested that child outcomes are significantly improved if we treat maternal depression to remission. So where mother's depression was treated to remission, there was an 11% decrease in rates of diagnoses for the offspring. Of the children who were diagnosed at baseline and their mothers were treated to remission, 33% of those children's disorders also remitted. So it's good data to support that if mother's depressive disorders are treated to remission, that has a really positive outcome on the child's mental health. Sometimes it's difficult to diagnose depression in pregnancy because there's a lot of overlap between the somatic symptoms that people experience in pregnancy versus those that people experience in depression. So questions about sleep, appetite, energy, and libido changes often give you less useful information. So specifically, when I'm concerned about depression in pregnancy, I ask about anxiety. I ask about lack of interest in the pregnancy and the baby, or like not preparing for the baby. Guilty ruminations, profound anhedonia, social withdrawal, and inability to sleep. Again, the sleep issue is also, as pregnancy progresses, particularly like in the third trimester, women also have a lot of physical discomfort and difficulty sleeping. So I would suggest that that also is not that reliable, but difficulty sleeping in the first and second trimester, I feel, is often more associated with depression. So certainly there's good data to support psychotherapy in pregnancy, and it's indicated particularly for mild to moderate depression or anxiety. And there's RCTs to support the efficacy of IPT, CBT, group psychotherapy, and psychosocial interventions. And they can also be very helpful in combination with pharmacotherapy. And again, pharmacotherapy is indicated for people with moderate to severe depression and anxiety, women who are considering pregnancy or are already pregnant and prior attempts to discontinue medications have failed, i.e. they have relapsed, and certainly for people with many episodes of previous depression, and people who have very severe depressions requiring hospitalizations. I generally don't take them off of their antidepressant medications. And as well, people with a history of relapse in prior pregnancies. In terms of like a screening test, there's the Edinburgh Postnatal Depression Scale. Very simple to use. It's a self-report screening tool, 10 questions. It's well validated, looking for a threshold of 12. It's very sensitive and specific, and also validated for depression in pregnancy and for postpartum and for adolescent mothers. And this is kind of what the Edinburgh looks like. So this is the 10 questions. And again, we're looking for a score of 12 or higher. So this is something that can be administered in, the regular pregnancy appointments, or the 6-week postpartum checkup is a good time for other treatment providers to administer the Edinburgh Postnatal Depression Scale. So in terms of treatment with pharmacotherapy, there's a lot of studies that look at antidepressants in pregnancy. There's a lot of databases from various countries. So we have large N's to look at these things. Baseline risk for having a baby with a major congenital abnormality is somewhere between 1% and 3%, and that's with no significant exposures. Looking at all of the antidepressant data, and there's like close to like 50,000 cases that they've looked at, there may be a low increased risk of major congenital malformations or neurobehavioral issues. So if the baseline risk is 1% to 3%, often with the use of antidepressants, it can increase to 3.5% or 3.3%. So there may be a small increased risk, but the increase is small. And certainly depression itself, untreated maternal depression, can cause decreased IQ and impaired language development in offspring. The actual depression is also associated with preterm birth, preeclampsia, low birth weight, and lower APGARs. And they found the same outcomes with the use of antidepressant medications. So all that to say that depression itself has these impacts as well. And the main difference that antidepressants bring to the table is the risk of the withdrawal syndrome. So with use in the third trimester, there may be a 10 to 30% risk of like a neonatal adaptation syndrome, where the baby can be a bit jittery, irritable, have some difficulty feeding, and rarely difficulty with breathing. And usually occurs 48 hours after, starts 48 hours after delivery, depending on the half-life of the antidepressant, and can last up usually less than a week, but sometimes up to 2 weeks, and doesn't usually require any other kind of medical interventions or ICU supports, and it just requires monitoring and the usual feeding and bonding and sort of care as usual. One risk that was identified in some of the studies was that the use of antidepressants were associated with increased risk of persistent pulmonary hypertension of the newborn. This is a very rare condition, so the prevalence is 1 to 2 per thousand. And with the use of antidepressant medications, it may increase to 3 to 4 per thousand. So still a very rare condition, but a serious condition should someone have that. So when I meet somebody who's pregnant and who's depressed, my first line treatment medications are usually sertraline or escitalopram. And I would choose one of those medications because they have the best safety profiles in pregnancy, and they're also effective antidepressant medications as shown by STAR-D and CAN-MET guidelines and other trials. Looking at other antidepressants, so mirtazapine is frequently used, but they like to have usually between like 500 to 700 case points before saying that a medication is compatible with pregnancy. And thus far, there's about 334 cases where they looked at people taking mirtazapine. There's a 2.9% risk of major malformations, which seems to be within the baseline. And often people use mirtazapine because it's helpful with severe vomiting in pregnancy. Bupropion, the registry shows 675 pregnancies, and there's a 3.6% rate of birth defects, so a bit higher than the baseline of people that have no exposures. And again, they're usually cardiovascular defects. Duloxetine, there's 668 exposed infants with a 2.3% risk of major malformations, so again, within the acceptable range. With venlafaxine, 3,186 exposed infants with a 3.3% risk of major malformations. Some studies have shown that there's a small increased risk of cardiac malformations with paroxetine and fluoxetine. Other studies have not replicated that, but I wouldn't necessarily start those in someone who had no previous trials of antidepressant medications. However, if someone came to me on any of these medications and they were doing very well, I would not switch them to something else just because of a lower theoretical risk of abnormalities. When we're treating depression in pregnancy, the principles that we like to follow are obviously monotherapy is preferred. And I think that's really in any kind of depressive condition, but more so in pregnancy, because the more medications we use, the more kind of risk to the fetus. We like to use the lowest effective dose. And I think effective is important here. We don't want to expose somebody to the risks of antidepressants and use an inadequate dose, because that seems pretty counterintuitive. And I would use the medication that worked best in the past. So again, if someone came to me and they'd done very well on paroxetine or venlafaxine or what have you, I would use those medications in pregnancy. So for people with postpartum psychosis or bipolar disorder, often they do very well on mood stabilizing medications like lithium and antipsychotics and other anticonvulsant medications. And I see a lot of people for pre-pregnancy counseling who are taking these medications and, want to conceive. And so lithium, the connection between Epstein's anomaly and lithium has been present in the literature for, the last 30, 40 years. And Epstein's anomaly is very rare. The baseline risk is 1 per 20,000. And with the use of lithium, it can increase the risk to 1 per 10,000. I've spoken with many cardiologists who have actually never seen Epstein's anomaly associated with lithium use. That being said, it probably does increase the risk of other cardiac abnormalities like atrial septal and ventricular septal defects as well, in the realm of up to 5%. So for women who take lithium in pregnancy, sometimes extra cardiac monitoring of the fetus is indicated. Using lithium in the third trimester increases the risk of having a baby with low tone. So we're pretty careful in monitoring levels in the third trimester and at the time of delivery. It can be a very challenging medication to use in pregnancy because particularly in the first and second trimester, as the renal metabolism changes, the lithium levels go down. And I'm not really chasing a level in pregnancy. It's based on clinical symptoms. So if someone presents with more depressive symptoms or more sleep difficulties, I would increase the lithium dose. And then in the third trimester, the levels seem to increase. And so often the lithium dose needs to be decreased in the third trimester. And then there's some disagreement in the literature in terms of what to do at the time of delivery. So what I do is, depending on what your level is at the time of delivery, if it's 0.8 or less, I would continue lithium. If it's higher than 0.8, I would hold the lithium when somebody goes into labor and then resume at the pre-pregnancy doses after delivery. And it's important to check the lithium level 24 hours after delivery, and then ideally daily for the first few days postpartum. So there's a lot of fluid shifts in delivery, which is one of the reasons that we're concerned about lithium, and particularly lithium in people that have higher levels. We want to avoid toxicity. One more point about lithium is many people choose not to take lithium in pregnancy, but there's very strong data to suggest that restarting lithium immediately in the postpartum period is very protective against having a postpartum psychosis or a postpartum depression. So particularly if you start within the first 48 hours postpartum, that decreases the risk significantly of having an episode. In terms of using other mood stabilizers, so Epival, there's an 11% risk of major malformations. So usually like 6 to 7% risk of neural tube defects with use in the first trimester, but it's not recommended to use in any trimester of pregnancy because it also affects cognitive originality and IQ at age 3. So generally it's a medication we prefer to avoid in pregnancy, and they have come out with like a new statement by the producers of valproic acid where they suggest that you don't use it in people of reproductive age who are not on contraceptive medication. And in fact, they suggest that they should be on an IUD or something that's more effective than even oral contraceptive medications. My usual approach for someone who I think valproic acid is like the best option is we have a discussion about that it can be a teratogen and it's important to try to avoid pregnancy and be on birth control. And I document that we've discussed all the risks and benefits of that. Carbamazepine appears to have a 6% risk of major malformations. Again, that's usually with use in the first trimester. That's specific more to neural tube defects. And lamotrigine seems to be the safest of the anticonvulsants. There were some studies to show that it increases the risk of cleft lip and palate from 5 per 10,000 to 5 per 1,000. These have not been replicated in more recent studies. And there's the theoretical risk of Stevens-Johnson syndrome with like rapid titration. So it still needs to be titrated slowly in pregnancy. And it's also affected by the renal metabolic changes that occur in pregnancy as well. So the levels can shift quite a lot in pregnancy. In terms of the antipsychotics, that is often the first line treatment these days for bipolar disorder and certainly for a postpartum psychosis. They generally have a good safety profile in pregnancy, but the data is still somewhat limited. We have less data on the antipsychotics, certainly than on the antidepressants. There is likely none to a small increased risk of major malformations, again, mainly cardiac, and they don't appear to have an effect on the second generation antipsychotics, don't appear to have an effect on delivery date or birth weight. There's specific concerns with specific antipsychotics, like olanzapine may put people at higher risk of gestational diabetes and preeclampsia. Preterm birth and low birth weight seem to be more common in infants exposed to first generation antipsychotics. And they also vary in terms of how much passes through the placenta. So generally we prefer to use quetiapine in pregnancy because it has the lowest percent passage through the placenta going from the mother to the baby. And that varies from individual to individual, but looking at all of the atypicals, quetiapine seems to be transmitted in the smallest amounts. In 2011, the FDA came out with a statement that infants exposed to antipsychotic medications are more likely to exhibit neonatal signs, so more like withdrawal symptoms compared to infants who are not exposed to non-teratogens. So the rate of these neonatal signs, similar to neonatal adaptation syndrome is about 15.6%. And these complications can include extrapyramidal side effects, tremor, muscle tone issues, breathing, feeding difficulties, sedation, and agitation. And again, sort of require monitoring in the postpartum period, but generally do tend to resolve and don't seem to cause further neurobehavioral difficulties in children later on. So I'm going to end there. These are some very helpful websites where you can look for information. Now that we don't really have access to mother risk in Canada, I do recommend that people look at mothertobaby.org. They have some very helpful patient handouts and information sheets about medications in pregnancy. Thank you.
Marianna, that was fantastic. Thank you for that. Very helpful coverage. It's a big topic, and you've covered it in a way that's obviously very practical. A couple of questions. One from Kayla. That being, is there a role for, and again, really short, pithy responses. We'll get through a few of these. Is there a role for omega-3 fatty acids in treating depression and pregnancy?
I think that's a good question. And the data seems to be mixed on that. I mean, omega-3 fatty acids seem to be helpful in depression in non-pregnant people, but in pregnancy, the Cochrane review seems to suggest that there's not sufficient evidence to support that. That being said, I don't believe they're harmful.
Okay. Marijuana, recreational weed during pregnancy, you recommend it or you don't recommend it?
I don't recommend it.
One final point, and that is divalproex valproate being the active moiety. We've had it since 1882. We've learned a lot about the teratogenicity in the last 2 decades, and you highlighted not just anatomical, but cognitive and behavioral. The question I have for you, this is coming from Roger McIntyre, is the following. We've been hearing from the OBGYN Society in America, in France, in the UK. Some of these organizations are saying, not only avoid it in pregnancy, not only use contraception, but don't use it at all in women of reproductive age. What is your own professional opinion in terms of the degree of proscription that we should be considering at the point of care?
I think it's our job to, explain this, what we know, the risks and benefits, and then allow people to kind of make their own decisions. I've had patients do very well on valproic acid and allowed them to have a very good quality of life. And I think it's not reasonable for us to have that treatment option removed based on these observations.
Yeah, I'd agree with that, Brianna, because I would say that certainly I've got concerns as everyone else does. I've been underwhelmed by valproate as a mood stabilizer. That's a different conversation. But I thought that it was a bit heavy-handed to completely say don't use it at all. Bipolar is a lethal illness, and I think we have to look at the burden and the benefit. So thank you for that indeed, and we'll come back to you. Don't go too far, Marianna. Maybe some Q&A.